Well, welcome back to the Clinical Leadership Podcast. I'm your host, Dr. Alex Earl, and I'm joined today by Dr. Jesse Doty. Jesse, thanks for coming on the show today.
It's great to be here, Alex. Thank you for having me.
Happy belated Christmas or Merry Christmas. Happy New Year to you and your family. And glad to connect with you on all things foot and ankle. And so do us a favor and just give a little background as to you, your training, and what ultimately got you to your current role in Chattanooga with Erlanger.
Absolutely. I'm an East Tennessee boy by heart. I grew up near Knoxville in a small town called Rogersville and attended Carson Newman College, where I was fortunate enough to have some of those instructors in your life that you never forget. And one of those was Frank Pinkerton, my organic chemistry professor, who really helped steer me into healthcare professions. And I was fortunate enough to spend 4 years at the University of Tennessee Health Science Center in Memphis, Tennessee, where I was able to obtain my MD degree. And then from there, I really was drawn to surgical specialties and surgical services. And so, an orthopedic 5 year residency, followed by a 1 year foot and ankle fellowship, where I could really focus on lower extremity reconstruction. And my orthopedic residency was in here in Chattanooga. And then that 1 year fellowship was in Boise, Idaho. From there, I did a little bit of sports management in Los Angeles, and spent some time with Rick Ferkel doing small joint arthroscopy and just sports injuries. And it's hard to believe it's been over a decade now. I've been in practice here in Chattanooga, Tennessee, and fortunate to be here. Really love the people, love the practice. It's a really diverse practice with patients of all ages. I take care of young athletes from around the age of 10 to a large portion of my practice is really focused on high school and college athletes. But one of the benefits of foot and ankle surgery is as many miles as we put on our feet, certainly patients from all walks of life. And so I routinely see patients who are still super active in their 80s and 90s. And so there's never a dull moment, a large variety of foot and ankle conditions, which you're well familiar with, and a large network of ages. And so it's been great.
Yeah, I think one of the reasons why I wanted to have you on the show is because I'm not violating HIPAA or anything. I'm the patient, right? So like is one of the few incidents where I've actually been a patient of the person I'm interviewing. And so I remember, just in the highly competitive Chattanooga men's soccer league, stepped on an opponent's foot as I tried to just poke the ball away and had your classic inversion ankle sprain. And I've had several ankle sprains, but that one, that one was one of the worst. And I remember going into your office and you guys were so kind to, get me in quickly. And I remember just thinking like, I feel like my ankle is hanging on by a thread. And obviously my biggest fear was, do I need surgery? Do I need to put this thing back together? How bad is it? That was like my biggest concern. And you walked in and you had your resident, you had your people with you. And you're like, yeah, you did a number, and you when you first touched my ankle, I thought I want to just like I'd rather just keel over, and I'm sure you get that a lot. So my biggest fears weren't actually involving my ankle. So one of the things I wanted to ask you is like the psychological aspect of lower extremity injuries, because they could be, and I remember one time you mentioned that injuries to the lower leg could be life-altering injuries. Could you expand on that a little bit more?
Yeah, and that can't be understated. I agree with you 100%. Your example is a prime example of someone where you depend so much psychologically. There's so much mental well-being that's dependent on our ability to participate and to move. God designed the body for motion. And so anytime that you become sedentary, it really has a drastic psychological impact. And for yourself, um, just with the degree of participation you do in soccer and all my avid athletes, anytime you sustain an injury like that, then it's a real hiccup to the rest of your life, and really to the rest of your um, schedule, because we schedule so many things around sports participation, around workouts. And I'm the same way. I have a musculoskeletal injury at least once a year, and mine, unfortunately, aren't really high octane injuries like yourself, where you push yourself to the extreme. For me, it's more of I'm gimping along on a treadmill and I pull a hamstring, or I'm trying to do some seated rows and I throw my lower back out. And, those injuries used to be something when we're younger, where 2 or 3 days and you're recovered and an anti-inflammatory. Whereas now, it can require physical therapy, it can require adjustments, it can require dietary influences. And honestly, probably the time commitment to recover from an injury has been the most difficult I've learned now that I'm in my 40s, just from those simple injuries that were a small blimp on the radar. Now, it may be 4 to 6 weeks, and you're trying to make sure you can get better before you go on your vacation with your kids, so you can ski with your kids, or so you can walk with them at the beach. And so I think, I love seeing patients like yourself. It's fun to see athletes, first of all, because they're highly motivated to get back to sport, to get back to work, and to get back to just normal activities of daily living. And so that makes my job a little bit easier. And then in your particular instance, someone who's well trained and well versed in the lingo, we can really just sit down and we can have a discussion where we can run things by each other and say, okay, these are the ligaments you tore, these are the tendons you injured, these are the bones you contused. Here are our options. What do you want to do about it? And we're fortunate in your scenario, where we're able to just restore some physiologic motion and get some normal tissue maturation, and able to do that without surgery. And so a lot of what I do is exactly what you alluded to. It's just encouraging people, reinforcing that they're going to recover, and just throwing out some ideas. And I really like to hit it from a multifactorial approach. And much of that approach early on, and with many injuries, is a non-surgical approach.
Yeah, so my biggest fear was, will I ever play soccer again? And so I like that you touched on how it's a major schedule disruptor. I obviously coach youth soccer here in Chattanooga, and I treat athletes in both Illinois and Tennessee, and that would be a major disruptor. Um, but my biggest fear is, like, I love to play soccer with my kids. So if it was an injury that drove a wedge in that, that would be life changing, because I find meaning and fulfillment in playing with my kids and coaching, their friends, so I get it, and I appreciate that aspect, the multifactorial aspect. Especially, you mentioned back pain. We know that low back pain is absolutely multifactorial. I can only adjust so many low backs, but if you have to go back to the same crummy boss, the same miserable life, then sometimes it's just, it's there's more. I think that, and I think more and more people are realizing that at least in the chiropractic world that I can speak to, I think patients are looking for more, and I think they're deserving of more. And so we're not as simple as just low back out, adjustment back in. I think we've moved beyond that narrative. But yeah, let's talk about a conservative trial, conservative care in the immediate aftermath to a lower limb, especially ankle, because that's probably what 80, 85. I'm kind of coming up with the statistic there. 80 to 85% of things that we'll see in the sporting world will be ankle sprains. Another subpopulation that we'll see a lot of in runners will be bone stress injuries. I'd love to touch on that with you in a minute. But let's talk about, like, what are some early stage strategies that we can utilize, conservatively speaking, for those ankle sprains.
Sure. So, and it's in the rawest, most simplistic form. Um, a lot of these younger athletes, and these are, you touched on the impact of sports on so many facets of life. And so if we go to my youngest patients, 8, 9, 10 year olds who are just doing basketball, little league soccer, and baseball, things like that, club soccer, then it's super common to experience an ankle sprain. And it's what you said, it's impactful because they've really built a lot of their social network around that sport. And so I think the most important thing is trying to maintain the social interactions around the recovery. And fortunately, now with athletic trainers and coaches aware of the injuries and with the resources we have, a lot of even the injured athletes continue to participate and be part of that team network. And so, as you're well aware, if you look at the statistics, a tremendous amount of ankle sprains, even daily. If you look at the US, it's about 23,000 ankle sprains a day. And fortunately, a very, very small percentage of those go on to necessitating surgery. And so most of those are going to heal by design. And really, the question is, what's the quickest way we can get the athlete pain free back to activities of daily living? And then, really, what the athlete wants to know is, when can I play again? Right. And so I think for the majority of patients, it's always going to be non-surgical for an acute sprain. And for me, the patients that end up in surgery are those that have had chronic pain for oftentimes for a year or two, or they've had a multitude of sprains where they say, look, if I'm on a gravel driveway, I sprain my ankle. If I'm walking across a soccer field, I sprain my ankle, and I sprain my ankle every day. But that's infrequent. And so a first time sprain, really it's about encouragement and then controlling the local inflammation and then restoring early motion without overstressing the tissues. And so with any injury, probably the hardest part to encourage the patient is rest. And with rest comes time. And I'm a full believer that time is probably the biggest friend of any clinician, and time heals injuries. And so I like to see the patient, tell them kind of here's what to expect over the next few weeks, and then encourage them just to rest for a couple days. It's not going to hurt if we can rest for 2 or 3 days, and then we may be able to still optimize and expedite your recovery once your pain's improved. And so those first few days, a period of an immobilization type device such as a boot or a brace can be beneficial. Cryotherapy, I'm a big believer in ice over heat. Heat can feel good and it can relieve some symptoms, but cold therapy really is going to decrease the inflammatory burden. So early on from an injury, I like to institute aggressive cold therapy, immobilization just for a short period to allow the soft tissues to relax just from that acute injury. As you're going, really that first 2 weeks, you're just going through the hematoma phase where you can, when you rupture some of these ligaments, you also can tear arteries and veins. And so you can get some tremendous swelling, which increases your compartment pressures, increases your pain, and stimulates the nerve endings. And so immobilization while the swelling goes down, cold therapy to decrease inflammation. You and I are on the same page as far as medications. We're not heavy medicinal users, but I'll be honest with you, pharmacology is a refined method of a lot of natural medicine. And so I like to use a lot of topical anti-inflammatories. I like using topical Pincid, Voltaren gel. If you're more natural, arnica, and all these things are readily available at the pharmacy. And so doing some topical anti-inflammatories can be beneficial. I don't routinely encourage long-term use of ibuprofen and Celebrex, things like that, but they can be a useful tool for an early injury, just to decrease the inflammatory burden and decrease the swelling. So if you immobilize and you ice and you do some anti-inflammatories for that first few days, really then you can get the pain under control, and then you can start to encourage motion within what's physiologically normal. The last thing you want to do is overstress or overstrain a joint when it's injured. And so you just want to do gentle motion so you can stimulate the tissues to heal in a more organized and mature manner. And all of our collagen synthesis around our tendons and ligaments responds to physiologic stress and motion, and it'll heal in a more organized manner with less adhesions and stronger tensile properties if you can start to move early. And so 2 to 3 days of rest. And then I think that's where gentle motion and ambulation can become beneficial. And then once you're restored your motion and you're starting to move the tissues and you're starting to get some healing around 2, 3, 4 weeks with an ankle sprain, then you can kind of start to protect but stress the tissue. And I think that's where things like taping and bracing are imperative for those first few weeks and months. And so you may be able to go back even from the most severe of sprains within a week or two back to sport. But I really try to encourage people to protect those tissues because they may still be healing for up to 6 months. And so you don't want to overstretch and overstress a tissue that hasn't restored its overall biomechanical strength integrity profile. And so if you can brace and protect while the tissue continues to get stronger, then in the end, you're going to decrease your risk of recurrent injuries.
Yeah, I love it because I think one of the things we're trying to communicate to, chiropractors, functional rehab chiropractors and physical therapists alike is that just because someone's this I've said on multiple, fronts is that just because someone's pain free doesn't mean that they're ready to compete. And so that tissue healing timeline, that confirms my bias, because I like to communicate to patients that, the swelling has gone away, the feeling, the pain state has been modulated or reduced, but that does not mean that those, the tissues have completely healed and that you're ready to compete. And so I just appreciate the way you said that because that's something that I've seen as well. So let's talk about maybe like the next stage. So when can we introduce some therapies? I know in my world, shockwave has become really popular, light therapy or laser therapy, and then blood flow restriction. Those are probably the three biggest tools that, non-surgical, conservative clinicians like me, and our listeners are probably more inclined, and some soft tissue, probably some needling, like dry needling and maybe even acupuncture type stuff. What are your thoughts on some of those? I know we've talked a little bit about laser before, but like, what about shockwave and blood flow restriction? When would you enter that into almost the clinical program for the patient?
I certainly encourage the use of those modalities. And I think the most important thing is it's exactly what you said. Number one, even though the symptoms may have abated, I encourage the patient to not re-injure and reset the clock because you don't want to take one step forward and two steps back. So if they're improved, the symptoms are starting to calm, then that's where you have to kind of rein in the activity and say, all right, let's start to stress this joint. Let's start to stress this injury a little bit in a good way, but let's not do it in such a way that you're going to re-injure and then take even longer to heal. And so I think the modalities you spoke of, one thing I always encourage is look, these are not a substitute for mobility and for motion. And that's why I think it's so important that things like this are really done under the direction of a clinician like yourself or like a physical therapist that can encourage mobilization of the joints and tissues and then substitution with these other modalities, which are just more of an addendum or a gain of function on top of the mobility and the physiologic motion. And my understanding of, and everybody responds differently, right? We're all a little bit metabolically different. And so I have patients who come in and they've benefited tremendously from more of the Asian type techniques and more of the acupuncture and dry needling. And then I have other patients who say, look, I got a little bit of benefit from that, but really with some of the adjustments, some of the pressure changes around the joint, some of the refinement of my range of motion and excursion, I've really started to notice a benefit. And so everyone's a little bit different. Personally, with my patients, one of the things I treat most commonly non-surgically is heel pain and plantar fasciitis. And it's any clinicians, it's a from our perspective, we may see 200 or 300 times a year, and it can become quite boring. But it's also job security, and it's also a really easy area to make an impact on a patient's life. And I've had a lot of success around these chronic myofascial type inflammatory conditions. And I just throw plantar fasciitis out because it's so common. Achilles insertional tendonitis is another common one. but where you're really trying to calm down that zone of transition where the tissue transitions from a softer type of collagen into a calcified collagen and then into purely calcified bone. And those transition zones are just common areas of overuse and inflammation. And that's one of the areas where I've seen the biggest benefit of some of the light therapy, the cold laser therapy, the acupuncture techniques, any of the things that can release endorphins or just change some of the biomechanical integrity of the joint based on excursion, stretch, feedback to the nerves, and even the biochemical markers and releases based on mobilization of the joint. And a lot of those things, whether it be magnetic or phototherapy, light therapy, really can change that local environment and optimize the healing potential of the tissues while you continue to mobilize the tissues. I think the worst thing you can do is completely immobilize and then rely on those techniques without the physiologic motion.
Yeah, I definitely would agree. I think that yeah, and I also look at it sometimes more so from the muscle aspect. The metabolic demands of muscle are very expensive, you know, so if you don't use it, you lose it, that kind of mantra. And some of that comes from my blood flow restriction background, where it's like as quickly as we can, getting the limb into a stressed out environment does really good things from a metabolic standpoint, and it preserves muscle. And so yeah, I definitely want to make sure that we are stressing the limb out safely, you know, and in a controlled environment. But I'm a big fan of blood flow restriction. Shockwave is another one for some of those conditions, like you mentioned. Very cool, very cool. Because I do think that going back to my ankle sprain, you know, if you were to try to mobilize my ankle, you know, within the first week, I probably would have, you know, smacked you, you know, because that just wasn't, you know, even sleeping that, you know, first couple nights, it was brutal, you know. I'm crawling on the floor to go to the bathroom because it's just bad. Like I said, it felt like my ankle was hanging on by a string. But these if these are slowly healing and we're getting some, you know, passive and active movement into the joint, you know, I like what you said earlier. That's like time is a wonderful remedy. I really do. So very cool, very cool. So let's switch over to the Achilles, because I think that that's something that plagues a lot of people. And especially as we kind of go from winter into the spring months, we're going to see obviously an influx of people, and we're in Chattanooga, so there's always people running, and there's always people you know, coming in from out of town for the half Ironman and the Ironman. So tell us a little bit more about your experience in treating runners or long endurance, you know, athletes with this chronic Achilles, because it's kind of it can be kind of challenging. It can be kind of tricky, if I'm honest, to deal with these kind of Achilles tendinopathies, Achilles tendonitis. So share your experience and what you've seen to work either surgically or obviously if there's a tear. But we'll talk about pickleball injuries in a second, because I'm sure you get a lot of questions about that. But let's talk about non-surgical approaches to Achilles tendinopathy.
Yeah, I concur 100%. It can be a tricky area. And I'll tell you, my favorite Achilles, and this is 100% cop out, but my favorite Achilles patient is the one that's either ruptured or they have such severe degeneration with partial tearing and calcification at the insertion that it's clear to me I need to open up, debride, and repair it. And those patients do well. And certainly in those patients, surgery is indicated, and so it's an easy kind of decision, and it's a can be a little bit of an arduous recovery, but the patients are generally happy in the end. The more difficult patient, which is I'm sure why you asked me, are these athletes, that these ultra marathon runners, these even the now that the Ironman became so popular in Chattanooga, athletes that are doing 20, 30, 40, 50 miles a week. That's quite common. And of course, you come across those athletes that can do a 50-mile or 100-mile one-time race, which is just incomprehensible to me. I'm lucky to get 3 or 4 miles out of my old body. But you know, those are the tough patients. And I think number one, it's tough because the amount of miles and the amount of steps that they put on their body. And so if you're doing a average 10,000 step day, that you're looking at, 30,000 steps a month. You do the math, you're at over 3 to 4 million steps a year. And then I never want to insult someone's age, but I look at my 60-year-old patient and I said, look, 3 to 5 million steps a year, and how old are you? And then I always underestimate and I say, look, you look like you're about 49 times, 5 million. And then they immediately get it. And so a tremendous amount of burden on the largest tendon in the body, the Achilles tendon, unless you want to split hairs and call the patellar tendon between your kneecap and your tibial tubercle a tendon, which it is by name, but it's truly a ligament that connects two bones. Remember, ligaments connect bones, tendon connects muscle to bone. And so the Achilles tendon, in purest of circumstances, is the largest tendon in the body. And if you look at the forces on the lower extremity, it's a tremendous amount of force across the hind foot and the ankle area. And so when you walk, just based on gravity, based on the shape of the joint, and based on the myotendinous forces, it can be up to 4 times your body weight. When you convert that walking into a run or a sprint, it's easily 7 times your body weight across some of those joints. Just looking at the physics of the Achilles tendon and the shape of the foot. So you have a long lever arm from the center of your ankle to your toes for push off. You've got this long lever arm. But if you look at where the Achilles attaches, you have a really short counter lever arm from the center of your ankle to the Achilles insertion on the hind foot. And so you can imagine the amount of force that your Achilles has to produce to push off and propel the body forward. And that's where we were talking about plantar fasciitis and enostopathies, where you have a soft collagen conversion into more firm calcified collagen. That's one of the reasons the Achilles insertion is so prone to inflammation, pain, injury, and chronic degeneration. And so these people who are running and continuing to put these forces on the Achilles on a daily basis, they're going to be more prone to these type of injuries that you alluded to. And I think the key, number one, is prevention. On the early side, trying to avoid the injuries with appropriate stretching of the Achilles, appropriate rest in between athletic events and in between training. And then one of my favorites is just the dietary influences of trying to optimize your intake of things such as turmeric, trying to decrease your carbohydrate intake, which can increase inflammation, trying to influence with amino acid intake, doing all those things to optimize the healing environment around the Achilles tendon and to avoid overuse injuries. And so once you have those injuries, then you have to talk about, and this is what you alluded to, the tricky part of an Achilles tendon injury. Do you rest it or do you move it? And that's what's been difficult for me is I'm so inclined to pursue motion, which I focused on early on in the podcast. And then I kind of sound like I'm a bit of a critic of myself. Um, but if you try to move the Achilles tendon too much and you don't give it appropriate amount of rest, you can get into this vicious cycle of inflammation that's hard to break. And I think that's why it's been such a challenge for clinicians like yourself. And you say, man, the Achilles tendon, it's not necessarily treated like the rest of the body. It's kind of a, a soul unto itself. And, and so I've found, more so than I really like to admit, I've found for non-surgical intervention of the tendon, early on, it's really rest and trying to take tension off of the tendon, place it in a boot. Sometimes I'll do heel lifts to take tension off of the insertion. And so you can do wedges in the heel and then immobilize for a period of a few weeks. And I think that's where the things you alluded to become supremely beneficial and important, because we're all aware of cast disease. Back in the 50s and 60s and 70s, orthopedic surgeons would put any injury in a cast. The problem is you get atrophy of the soft tissues, you get osteopenia of the bone, you get stiffening and contractures and fibrosis of the joints. So a cast is not generally a solution for much. And I don't want to downplay it for the first few days. But once you're past that first few days, or if you have a chronic injury, then typically a cast isn't the answer. So you may have to immobilize to decrease some of those tremendous forces we just talked about. You may have to immobilize in a boot or add a heel lift or a wedge to decrease some of that force. But a guy like you becomes imperative to do some of those strengthening, some of those exercise modalities where you're doing the oxygen restrictive therapies. You're combining that with doing the shockwave therapy to still stimulate that local environment to heal. If you do nothing to stimulate the environment, then it's just inert and you develop this anaerobic, unhealthy, mucinous type tissue. And so what you have to do is figure out how to allow the tissues to rest just enough that they can begin to heal. But then what do you do to stimulate the biomechanical and biochemical environment to optimize that healing capacity while the patient's not walking or exercising or stressing the tendon? And that's where I think the other therapies become super beneficial.
Yeah, I mean, we kind of have a mantra at our office that we want to get you off the treatment table as quickly but as safely as possible. We don't want to be, the patient to be dependent on provider or the clinician's passive modalities. We want to safely get you progressing, and sometimes it's just balance work. Sometimes just getting you to stand on one leg is just like the proprioceptive input. Goes a long way, and we do like doing heel lifts, and we like doing different exercises for the Achilles to try to mitigate some of the compressile forces like you mentioned, because we know that the Achilles needs both compression and tension, but sometimes we overdo the tension and sometimes forget about the compression that may have even been implicated in the injury back in the beginning. So no, I like it a lot. For the clinicians that listen to our podcast here, what are some things that we should keep in the clinical, maybe we call it the clinical reasoning process, that maybe we should make friends with a foot and ankle surgeon? And I'll ask about podiatry next, but what are some things that we should consider having, maybe not your cell phone, but like someone like you in the referral network, what clinically speaking, what should we do if we suspect this person actually needs something beyond my scope? What's your advice that you would have for clinicians?
Yeah, I mean, I think you want to find first and foremost, you want to find a clinician that you trust. And I mean, I want to be able to send the patient to you, and then it's just hands off for me. I want you to employ all the modalities you have at your fingertips. And so, in your scenario, that's going to be the cryotherapy, the adjustments, the excursion range of motion of the joint, any of the light therapy, shockwave therapy. And I want you to that stuff better than the surgeon. And so for me, if I have someone in your case, I can just tell the patient, hey, look, I have an acquaintance, Dr. Earl. He's got a great reputation. This is what he does. I'm going to send you to him, and I'm going to be hands off. I'm going to see you back in 3 months. If you're better, cancel that appointment. Call me when you need me. If you're not better, then he's going to try a multitude of different way attempts at getting you better. And if you're circling the drain, you've plateaued or you've digressed, that's when we start talking about more advanced imaging modalities such as an MRI. And with the MRI findings, of course, comes the initial discussion of, okay, is this surgery or not? And again, I don't encourage patients. I don't. It's rare. I don't want to say never. If I feel like I can really help someone and they're in denial, then I might encourage them to pursue surgery. But generally, in injuries like this, I don't encourage the surgery. I just say, look, here's our options. We've tried non-surgical modalities for 6 months or a year, or some of these patients may even say 3 or 4 years. Here's the surgical option. Here's what the data suggests the outcomes are. And I'll say, look, I think this would be beneficial for you if you're ready to pull the trigger on something operative. And if you're not, there's no rush, there's no urgency. Most things, one of the reasons I love orthopedic surgery is because, number one, most of what I do is not an emergency. A lot of what I do is elective, which just means it doesn't need to be done in the middle of the night, and it can be scheduled at the patient's convenience. And for a lot of those people, it may have something to do with holidays, travel, or their job, or their children. And so it's an easy discussion for me at this point in my career. I just lay out what the operative treatment is. I suggest what the outcomes to be expected are. And then I tell the patient, look, if you're tired of living with this, if you feel like you've digressed or your function has been affected in such a way that you don't want to continue enduring this experience, then I do think surgical intervention would be beneficial. You just have to let me know when the least inconvenient time is for you to undergo the surgery. And then I can kind of lay out the recovery so they know what to expect. But even in those scenarios where it's a surgical condition, I always default back to number one, it's on their timeline. And number two, if they want to go back and try the opposite, if they were resting and doing light therapy, if they want to go back and try shockwave and try more aggressive therapy, and because some of these things can be non-conventional, then it doesn't offend me at all. Go back and try those things. And so routinely I'll send the patient back to someone like you, or back to a physical therapist, and we're still on the same page. We both understand, hey, there's a limited chance this is going to work. But if the patient's committed to trying and exhausting all the non-surgical modalities, there are a litany of things we can try. And that can be from aggressive physical therapy and motion to the complete opposite end of the spectrum, which would be, to me, a solid ankle foot orthosis. That's essentially a boot that's just less cumbersome in brace form, that's going to immobilize and take some of those painful forces off. And so I may have an 80 or 90-year-old who still travels the world, wants to avoid surgery. And so a custom brace is the answer that they're looking for, and they do quite well. On the same token, I've had those who thought a custom brace was an answer, and they come back to me a year later, even at the age of 80, and say, I'm tired of doning this brace. What's my surgical option? And there can be a surgical solution that can be afforded at that time. But in that scenario, neither the patient nor the surgeon rushed into doing something in the operating room.
Sure. Yeah. Yeah. I think that's fair. We also, consult, and we help chiropractors and physical therapists run their practice from the business and logistics standpoint. And one of the things we try to do is try to present the patient with a plan of care that's basically similar to what you just said, one that might be, this road, or option A, option B, right? And I think giving the patient a choice, I think that should be a part of patient-centered care. Obviously, you create the plans, you present them, and you also explain, the benefits and risks of both, and then they get to choose. Because a strange thing happens, this, when they choose the plan, they've got ownership of it. Like you give the guidance, and ultimately, if they choose the plan, then I should say they're responsible for the outcome, because outcomes are unpredictable. But I do think that there's a level of ownership rather than this like kind of hands-off approach. Well, I don't know, my doctor wants me to do this, this, and this. It's like,
Sure.
well, no. As a
Yeah,
patient,
you
you do
need
have,
you're
yeah.
exactly right, Alex. You need buy-in. And it's
Mm,
not that I don't want to take responsibility for any of the decision, but if you it'd be egotistical for a guy like you or me to meet a patient, talk to them for 10 minutes, and then to lay out their entire plan of care when we're not really familiar with their social situation, their occupational situation, their emotional and psychological. It's somewhat hard to, you can get a lot of information in 2 or 3 minutes just by listening to the patient. I try to do that. But then you really want to do exactly what you said, lay out the treatment options, and then help them to formulate a smart plan that's best tailored around their life. And so I love that. And I think it leads to a much higher patient satisfaction rate. And honestly, I still think we get to the same place. Eventually, we're going to figure out and get to the solution. A lot of patients figure it out themselves, and they just need encouragement, or they need time, or they need a couple other modalities just to help break that inflammatory cycle. And then other patients, it can be more difficult. You try a number of things that usually predictably work, and for whatever reason, you don't get the same response. But I think in that scenario, it's even more beneficial that you've let some time pass so you can get to know each other better, build that trusting relationship, because obviously it's going to be a harder cycle to break. And it's going to be harder to get to that final healing potential.
Yeah, yeah. And some of that has to do with like the culture, the environment of the office. And so that's a nice segue into kind of you and the team that you have. Share with our listeners about kind of your support staff and the team that you basically oversee in Chattanooga.
I'm very fortunate to have, I've got a lot of great team members. And I mean, a lot of that starts with just with the culture and the environment within the office. And so that's I think in its simplest form, the most important thing is just to maintain an environment where people enjoy coming to work and they get to continue to move and interact. I've found that it's easier to keep those people happier in the clinic who get to interact with patient and have that social networking than those who are behind the computer screen and answering the phone all day where they can't put a face with a name. But I think the probably, it's one thing that's been hardest is the volume of patients that now clinicians are expected to see. That's something I've seen change over the past 10 years. I remember during my training, my mentors and just their patient load and the time they had between patients. And this was really in the early days of EMR before it was refined. And so, they had more time between each patient. They had more time to spend with each patient. And now, it's one of the things that's come with, there's been a lot of good that's come with data analytics. But one of the things that's become more difficult is just this numbers game with volumes and looking at, you should expect to spend 12 minutes on a new patient visit. You should expect to spend 7 minutes on a post-op visit. On your established patient follow-ups, we anticipate those are going to average 6 minutes. And those are just some examples of what we've been able to do with this analysis of all the numbers we have now with the computing power, which I think has been number one. I'll first to admit it's been great. We've made a tremendous amount of technological advances around computing, but one of the things unfortunately it's done is it's depersonalized the relationship between the clinician and the patient, and I think that's what we've acknowledged now as a society and we're trying to work to overcome. And so with all these benefits and refinement of the analytics, what do we do to continue to personalize a relationship and spend time together with human interaction? Because so much of the healing comes with the human interaction piece. And that's where I think that's an important part of all the therapies that you and I talked about today. And one of the things I like about your practice is the time you spend with the patients when you're doing the therapy, when you're doing the exercise, you're doing the shockwave. It's one-on-one time with the patient where there's rarely a silent moment, and you're going through a litany of other things you can encourage the patients to do that's going to benefit their overall health and lead to a better healing environment. And so much of that is mental. And so in the office, from the time we room the patient, the MA rooms the patient, I have two APPs that do a lot of the non-surgical care in my office, do a lot of the post-op follow-ups. And so if on the front end, you can manage the expectations of the patient and help them to understand that as a surgeon, a lot of times I'm going to be in the operating room, so I'm not going to be able to see them for every post-operative visit, but trying to introduce them to my PAs so they know who they're going to see and what to expect, and they can become confident in that treatment modality. Because the truth is, while a lot of patients just want to see the doctor, what they don't realize is my PA sees a numeric number exponentially more post-op wounds than I do. And so the care is not really compromised. They're seeing someone more routinely who sees a lot more post-op wounds. And so it's been an area of refinement over the past few years in this country, and I'm sure it will continue to change. But the business stress that's as our healthcare system continues to evolve is something that I think we've endured, and we're all trying to learn about together because we're in this together. And it's important to remember the patients are in this with us. We don't, it's not the clinician against the patient. It doesn't have to be that way. And that's what I've seen so much with with insurance changing, and with I'm having to do a tremendous amount of peer-to-peer reviews with, and I'm on the same team as the patient. The patient and I are working together to try to encourage their insurance to pay for what's right and allow the therapies and modalities that we think that the patient needs. And so it's been an interesting time, and I do feel optimistic that more and more people are acknowledging and understanding that we have some obstacles we need to overcome to optimize our delivery of patient care.
Yeah, I think because we've all been there, right? We've all gone into those we'll call them cold, even the colors of the wall and like the just the medical system, if I may. And then you go in there and you're talking to usually it's a lady behind the desk who you're an inconvenience when you show up for your appointment. And there's like 15 things that he or she is doing behind the desk, and you're like a burden to the office that you're supposed to be seen by. And so I like what you said, like you're on the same team as the patients. I found myself saying that as well. And again, I've been to your office, I've been treated by your staff and your team, and I didn't experience any of that. It was like a lot of people in the waiting room, but everyone kind of knew what to expect. Everyone had a smiley face, which is honestly, it like set the expectation before I even saw you in the exam room. You know what I mean? So I was already having a good experience even though I was, physically suffering. So I think that that plays a huge role in it, because we've all been to the DMV, we've all, had those negative experiences. We don't want that to be, kind of how we experience healthcare, in my opinion. So, very good, very good, cool. So we're kind of wrapping up 2024 here. What's on the horizon for you as we enter into 2025?
Well, it's a tough time of the year. We all look forward to Thanksgiving and Christmas and family time, and it's a bit of a catch-22 though, because Q4 brings so many challenges when it comes to the way we've structured the business of healthcare, and I'm alluding to the a lot of patients have met their deductible, and it's interesting that reset often happens on January 1st rather than on the patient's birthday. And so you just have this kind of national um, culmination of deductibles that have been met by Q4, and patients benefit from having their surgeries done by a certain date, which can put pressure on the non-surgical treatment as well, because all the things we talked about, the importance of non-surgical intervention. When I see a patient in October or November and they say, look, if I'm going to need surgery, and if I've heard it a million times, Alex, if I'm going to need surgery, I need to have it before January 1st. And I just said, that's why I said it was refreshing to get to see you as a patient, because you understood the constraints. You also understand the body. And I try in a very professional way. I'll tell the patient, look, I'm not clairvoyant. I'm not 100% sure if you're going to need surgery. And the last thing we want to do is to force a surgery when you may have gotten better without it. But if it's already October or November and you're trying to acknowledge the impact that a surgery is going to have on the wallet or the pocketbook, then that can be difficult, because you want to do the ethical thing. You want to try the non-surgical intervention if it's going to work. If you know that physical therapy or these modalities don't have a great track record for the condition, but you still have to jump through the hoops so you can check the boxes for insurance, then you say, look, we have to do therapy or they're not going to approve your MRI. And they say, well, doctor, this has gone on for 4 years. And I have a huge, you can see that huge spur on my x-ray right there. And I acknowledge that, but we're going to have to do some therapy. Well, that really pushes you up to a certain date, December 31st. And so that's the challenge of Q4. And in its simplest form, it's beneficial for me to be busy this time of year. And so I try not to complain. But I can tell you when January 1st rolls around, there immediately it's a burden lifted off my shoulders and there's less pressure. And I feel like even though I don't change the way I practice every January 1st, a lot of what I do is the same from one day to the next. I feel like the patients are a little bit more at ease. I feel like there's a little bit more less pressure on my office staff, and I feel like we're still going to get to the whatever the patient needs, but we're not having to deal with the impacts of the calendar. And so for me, a lot of January is catch up. I'm already super busy in January because it's music to my ears in November or December when someone says, "Hey, I want to have surgery, but I don't want to do it till January or February." So those people are already scheduled. I try to well, I do have a good time around Christmas Eve, and I worked this whole week. I was off Christmas Day, which was nice. But it's been a huge push to the end of the year. And so I always try to take off a 3 or 4 day span in January. And so this January, it's actually, and a lot of times that's still centered around work and education, but I'm going to do the American Foot and Ankle Society meeting this winter. And so that'll be a 3 day span, but I'll take my wife and hopefully have a nice dinner while I continue to learn and expand my horizons. And so for me, January and February is kind of a reset button, and then we kind of look at our office processes and see are there areas where we can enhance patient care or enhance efficiency just to increase the patient experience, so they're not spending so much time in the waiting room or spending so much. Our phone answering rate was a real challenge, and when I found out how many calls were dropping, that can be disconcerting. And so I think January and February forward a time that you can refine some of those processes.
Awesome. Yeah, because I think one other thing we have in common is we both teach, right? We both are educators for our profession. So do you have any speaking engagements lined up in 2025?
Yeah, I do. I mean, I'll be speaking at that Foot and Ankle Society. I'm moderating a session on sports injuries, which will be fun. And then this Q4, it was interesting. I try to travel more during the summer, but this has been a busy Q4. I had a meeting in Vancouver where we talked about total ankle replacement, we're doing bigger deformity correction. And so severe varus or valgus of the ankle used to be treated with an ankle fusion. And my generation is less inclined to fuse a joint and more inclined to try to pursue a replacement and maintain mobility. And so we were in Vancouver back in October to discuss that kind of corrective type surgery. And then I was in India the month before that. I've been fortunate enough to make a lot of connections with the Indian Foot and Ankle Society. And this was my second time to India, which is always a cultural experience.
Yeah, how was
And
that?
gosh, I went in 2019 to New Delhi, and it's a real challenge for just to think, watching what you eat, watching what you drink, and but it's also it's the I think experiencing that really builds character. And so we went back this year. We were on the West Coast, Kerala, India, which is we flew into Cochin, and I actually took my wife Kristen with me, and I said, "Look, you have to experience this. I want you to kind of see. It's you've got 20% of the world's population right there in that country, and so a lot of people who, for the most part, get along and are very welcoming to Americans. And so I've been fortunate to build those relationships and then got to experience that with my wife and get to teach and learn and see how they're doing things. And so it makes, even though I'm there to teach, oftentimes I learn a lot about other techniques and do some things that I can incorporate into my practice. And so hopefully continue to do that some this year with some of the international stuff.
Awesome. Excellent. Well, maybe we'll have to continue on, and maybe we'll have to get maybe a collaboration where it's a MD, DC, PT education. And the nice thing with Zoom, right? Like ever since COVID, as long as you have an internet connection, we can share information like this, quite easily. I still am a big fan of in-person seminars. I think the creativity and just the atmosphere is lost on Zoom, to be honest. But I think if we could do something on Zoom down the road, I'm kind of just creating, this is the entrepreneur in me, just coming up with ideas as they, come into my head. Some type of collaboration, the non-surgical and then surgical, lower leg, especially with pickleball. We didn't really talk about pickleball, but I'm sure you've seen just a massive influx of pickleball injuries over the last few years, haven't you?
It's the fastest growing sport, man. And you know, I think it's because, and I'll give you an example. My daughter, she's super active with soccer, and my son, I'm like, well, do you want to play soccer? Well, you have to run too much in that sport, Dad. And so I think the thing about pickleball, you get to enjoy tennis, but you don't have to run as far. And so it's been funny. It's fun to watch, and it's interesting, and I love it because with even though you see a higher incidence of injuries, the reason we're seeing more injuries is because there's more people playing, right? And so we have a lot of patients who are in middle age or later in life who are enjoying the camaraderie and the social aspects of pickleball, but also the physiologic exercise benefit. And so I'm a huge fan. I've played a little bit. It's fun. I have to be careful because at my age, Achilles tendon ruptures are super common. And I
Mhm.
just had, I had one of my best friends growing up last Thanksgiving a year ago. He called and we have this thing called the Turkey Bowl where we play flag football. And I said, dude, I'm getting a little old for that. I'll come watch. I don't really want to play, man, because every time I play, I end up injuring something and then I can't do my workout and it sets me back and I just don't feel as good. Um, and he's running his mouth and I was like, look, one of these days you're going to rupture your Achilles. And sure enough, I don't know if I jinxed him or what, but he texted me that weekend. He's like, you're not going to believe this. And so it was a complete rupture. And in the United States, in a young active patient, we usually fix those. And so surgically fixed him. And fortunately, he's back to duck hunting and turkey hunting and doing all the things he enjoys, but not flag football. And then I had another dear friend who was at a pastor's conference recently, and he texted me and said, you're not going to believe this. I thought something hit me in the back of the leg. I turn around, nobody's there, and my Achilles just
That's a
rolled up.
telltale sign. That's a telltale sign, isn't it?
I said, "Oh no! I mean, just based on what you told me, I can tell you without an MRI, you've ruptured your Achilles." And sure enough, and it was a pickleball injury. And so I sent him. I just got the it was, I believe it was the December Foot and Ankle International. That's the primary journal that orthopedic foot and ankle surgeons read, and it was an article, an abstract on pickleball injuries and the incidents, and Achilles was by far the most, and also the highest incidence of necessitating surgical intervention, Achilles. And so if you're a pickleballer, you got to be careful. Fortunately for you, you're in such good shape with all your soccer fitness.
I think it's the changes of direction in certain sports like hockey and tennis and soccer that probably prepared most people for the adaptations into pickleball. Um,
Yeah.
but yeah, well, two things for you, and then we'll let you go. The first is that I think it was a while ago, but I believe I read a British Journal of Sports Medicine article that talked about the highest risk factor for women over the age of 40 with a Achilles injury from pickleball. Number one risk factor, women over the age of 40, was waist to hip ratio. I thought that was really interesting. So I like what you said earlier, way back in the show about nutrition and talking about dietary lifestyle changes, because that to me I was not expecting that. But it does, to me, it does make sense, because the force, as we say with a lot of our patients, the force has to go somewhere. And the Achilles sometimes is the, that culprit all the way at the end there. So, or maybe the victim, I don't know. So then the second thing I was going to say was, you mentioned in the active individuals, active population, you recommend surgical intervention. Are there cases with Achilles full ruptures where you don't seek a surgical intervention?
Yeah, it's interesting. We could do an entire hour just on that discussion, and it's a topic of debate. And you mentioned that the benefits of the in-person meetings, which I agree. But one of the topics of debate we always do is the discussion of operative versus non-operative treatment of acute Achilles tendon ruptures. Um, the proponents of non-surgical intervention would suggest that there's a lot of data that shows that patients who have a rupture can do well. And yes, that's 100% accurate. But the problem is, if you really drill, you can make statistics show what you want, right? You just run a different statistic analysis. But if you drill down and look at the raw data points with non-surgical intervention, you're going to lose some of that terminal plantar flexion velocity and push off power. And so that's unacceptable for a lot of athletes, a lot of younger patients who are in professional sports. We see a lot of Achilles tendon ruptures in NFL and college athletes. And those patients, they have theirs fixed because their professional career depends on it. Now, patients who are more sedentary, and without even going down the path of smoking and diabetes and all the things, clearly those patients can be non-surgically treated. But patients who are more sedentary and they're on the cusp of uh, age or activity level where there are some studies that would suggest those patients can fare quite well with surgery, and most of them can. But the issue is you've got to try to extrapolate those patients that aren't going to do well without surgery. And so in this country, and I usually try to present the data, the raw data, and say, look, I don't have a problem at all treating you non-surgically, but you need to understand you're going to lose some of your tone, you're going to lose some of your push off strength. And so, like someone like yourself, I'd be a bigger advocate of fixing it. You're not going to be happy if there's a lot of elasticity and a lot of length built into the system, because it's like adding two chain links to your bicycle chain. You have that delay, you have that hiccup in your giddy up, and you're not going to tolerate that. Now, my father-in-law in his 60s and he's late 60s, he goes to the gym, he's still very active and very healthy. He'd be someone who might do okay with non-surgical treatment and be equally as satisfied. And that's really what you're trying to tease out in the office when you meet the patient with the acute rupture. But
So there's not really.
there's so many studies now, Alex, on what you just alluded to, trying to compare surgical to non-surgical intervention. And the problem is, it's the while it is some good data, you can't draw a hard line or a conclusion on just the data in each of those studies, because not all Achilles tendon ruptures are the same, just like not all femoral neck fractures are the same, not all Lisfranc injuries are the same. And if you treat them the same in every patient, you're not doing the best thing for each individual. So you have to look at the demographics and the individual and then decide, hey, is this something you're probably going to do better off if we fix? Or is this something where you can avoid the risk of surgery and you're going to do fine anyway? And a
I,
lot of that depends on not on the type of rupture, but on the age of the patient and what they do.
Yeah, yeah, I think I love it. I appreciate that so much, because that fits my bias, like one of the questions we try to teach younger clinicians is who's in front of you, and so identifying, the person's, environment, attitudes, beliefs, motivations, that's crucial. So no, I appreciate it. That's why I want to have you on, because we've
Yeah.
had little small conversations here and there, but it's like I'd like to get a little deeper, glimpse into you clinically, and I think we've done that. So yeah, I think that to summarize that, I think it would be that there are no solutions. There's only trade-offs, from the repair to, to non-surgical. So yeah, cool. I think that's a great place to stop. Where can our viewers or listeners, where can they find more about you? Are you on the internet? Are you on the socials? Are you on the interwebs?
Oh yeah. Yep.
Yeah.
Where there's a website, you can just Google my name, or you can have a website, jessedotymd.com. And, most of I try to do some blips on the most common injuries I treat and just lay out there. A lot of what I do on that website is just to explain the pathophysiology of the disease process, so that when the patient comes in, there's some rationale around our discussion. Sometimes there's some pictures around the surgical aspects, but really just trying to explain to the patient what's going on, so that then they know which questions they want to ask when they come to meet me for the first time. And then they can better navigate their treatment modalities.
Excellent. Well, definitely, I'll include all those links in our show notes so our viewers and listeners can, get in touch with you as needed. But yeah, thanks for coming on. Really, it's been a gift. Thanks for giving me a little bit of your Saturday morning here. Happy New Year to you and the rest of the family. And yeah, any closing comments, questions?
No, sir. Thank you for having me, Dr. Earl. It's been a real pleasure, and I look for it. Would I agree with you? It'd be fun to have a group of clinicians where I don't feel so strongly the need to justify non-surgical intervention, and I can tell you a little bit about what I do in the operating room, and then defer to your expertise on a lot of those non-surgical modalities. And maybe we could take a deeper dive into all those things from the technical aspects.
That this is right up my wheelhouse. I love kind of figuring out like where does my, road end, and if my road ends with a patient, what are my options? It's kind of like if then scenarios, and then who do I have that I can refer this patient on, and they are, in sync with me, or I'm in sync with, their way of thinking. And I've got a couple of providers in Illinois that, if I send them a patient, like 95, 96% chance they're getting surgery because we're in sync. We understand what each one of our roles are, and we stay in communication. That's the other thing, like we stay in communication with one another so that um there's nothing lost in translation between patient visits. So no, I would love that. That'd be pretty cool to kind of get a PT, a chiro, and an MD talking surgical versus non-surgical interventions of the lower leg. That'd be pretty cool. Maybe I'll have to put something together. But no, thank you for coming on. I'll let you go enjoy the rest of your busy day. Seriously, I appreciate it, Doctor. Thank you so much. And for those of you, we'll have this website up with all the show notes pretty soon here. And until next time, I will talk to you later.